Thank you very much, and thank you, Nigel, for setting the scene. It is good to be in the Carlsberg country, sort of where LMC sort of get better and better. And I think you sometimes sort of don't necessarily appreciate what you've got in your own home place, but actually I do tell you that what you get in Wessex and Wessex LMC is streets ahead of sort of many other areas, and I think sort of that's down to the team that Nigel leads and the work that they do for you, and I think it is really to be commended, an example really for many others to follow. I'm going to really just give you a feel as to what you probably already know, or should already know, which is why GPs are unhappy. Why are we moaning and groaning sort of about our current lot? Touching on a little bit about the imposition that is now 6 months old, and you really should be getting to grips with that in your practices, I guess, now, and should be much more familiar with the realities of what's happening, although it may only start to bite in the next 6 months as you start to realise how difficult some of these targets and challenges are. So I'm going to refresh you about sort of what's happening in reality, but then move on to some of the wider challenges and maybe a little bit about what we can do and how we can respond. Undoubtedly, sort of the big issues are workload. It's the sense that you can't deliver the quality of care that you really know you could do if you had the time and space to be able to treat your patients as you know you could do, as you were trained to do. There's issues about reduced income. There's the constant attacks in the media. Rather than Jeremy Hunt sort of appearing on the Today programme saying how wonderful GPs are because patients say so, and the sorts of figures that you've just seen Nigel present there are mirrored in the national surveys where GPs consistently come top of the pops, not fourth or ninth. They come top in terms of patient satisfaction. And yet, when did you last hear a government minister sort of appearing on the news or elsewhere saying, aren't they doing really well? There's always that undercurrent of, there's a problem here, this needs to change and whatever. And so this constant drip effect, that's another reason why GPs feel so unhappy. But then there's the fear that worse is yet to come, that we're just about treading water at the moment, we're just about keeping our head above the water. Sometimes it feels as if we're bobbing below it every now and then, but there's this fear that it can only get worse, rather than a hope that it could, if we seize the agenda, get better. So just to remind you about what the reality is at the moment, you remember that the changes that happened in the contract were imposed upon us. They weren't negotiated, they were imposed by Jeremy Hunt, the very man who is now going around saying that there's too much bureaucracy, too much box ticking, all the rest of it. Actually, what he imposed made the QOF and various other elements of the contract significantly worse. Part of the imposition, which really hasn't started to grip yet and which will start to have the biggest impact, regardless of all the QOF changes and desk changes, is actually the change in your core funding, the funding to GMS practices and PMS practices. So there is a plan for a 7-year movement of funding to try and equalise payments per patient per practice. So as part of that process, the correction factor, if you've still got one, will be phased out over a 7-year period. So every 7 years, you'll get a seventh of your correction factor chopped off. That won't disappear to the profession. It will be reinvested in the pot, but it won't necessarily stay with your practice. Your global sum level will go up, but your correction factor will go down. There's a review been going on about PMS practice and PMS practice funding, which has got to a point where they're now starting to consider how much of that resource will be recycled as well, and whether that will be a 7-year process as yet remains to be absolutely clear, and how much of that funding will flow into a merged pot of PMS and GMS funding, again, remains to be sorted out. The government imposed all of the QOF recommended changes that NICE had on the shelf, not just the ones that sort of were on the mandate for this particular year, but everything else that we'd resisted in the past. Everything just came tumbling down on top of us, whether it was good, bad, or indifferent. And one of the other things which has made a big difference to workload has been this shift from allowing you to have 15 months to get your QOF points sorted out to a 12-month window, which actually narrows it down to potentially 9 months to actually do the work properly. There was big changes to QOF indicators, particularly sort of the upper thresholds were increasing, making it that bit more difficult to achieve them. But not just this year, but in future years, because every year now, if things don't change, those QOF thresholds will change as we strive to do better. Actually, the goalposts will get further and further away. It's a bit like a mirage in the desert where you think you've got to the waterhole, but actually it's moved beyond you yet again. And there'll be a real risk that it becomes much, much more difficult year after year to hit those upper QOF indicator thresholds. We lost 100 QOF points, the ones that we were all really achieving. Those 100 points were removed from QOF and used to fund the new DESAs. And a little-known change, which was the reform of the Contractor Population Index. This calculates how much funding you get for QOF. And it's linked to the size of your practice and the number of practices right across the country. So it's a calculation that ensures that the funding is distributed with the available QOF resource across the country. What it does mean is as practices get bigger and their list sizes get bigger, the number of practices shrink overall across the country, as has been happening year on year, the actual available resource potentially for QOF shrinks unless you put more money into it. And one of the risks is whilst the government committed to put that extra money into QOF this year, they haven't done for future years. And so there is a real risk that this becomes a year-by-year erosion of the value of QOF overall. There's been a whole series of immunisations, which I'll come on to shortly, and then significant new work for DESAs as well, which I'll also touch on. So, why are GPs unhappy? Well, I've already touched on the big issue, which is workload. GPs are just overwhelmed with the work that's coming through their door. There is a lot more box-ticking, micromanagement of practice, which is really unacceptable and draining and deprofessionalising. And this sense of trying to have to scrape and change and get to every single QOF point of every single indicator, not only from QOF or the DESAs, but maybe what your CCG is also asking you to do as well. And much of the new QOF changes were underpriced, so the number of points available don't match the work that's required to actually achieve them. There's the shifting goalposts, which are causing major problems. Chasing QOF points at the margins becomes less and less sensible because of the cost of sending out lots of letters or reminder letters or chasing them up. Actually, you spend more than you actually do in terms of achieving those QOF points. So you need to be very careful about doing that. I've mentioned already the reduction in the time available for those targets. And then in some of them, there's the requirement for additional training, sort of the diabetic indicator that requires a suitably competent professional is maybe okay for diabetes, but it's potentially the thin end of the wedge, this micromanagement agenda, where you start to get NICE saying, well, you have to be suitably qualified to provide dietetic advice, maybe you have to be suitably qualified to provide asthma advice or COPD advice or dementia advice in the future. There's a real risk that we sort of have those, that micromanagement agenda of our education and training. All of this together has an impact on your ability to provide enough appointments for your patients, because so many of your appointments are taken up by the chronic disease management agenda, by you inviting people in just to get those QOF points achieved. And that then, as we've seen sort of in the press recently, has an impact on secondary care. We warned Jeremy Hunt that the imposition of the contract would have an impact on access, not just in primary care, but in secondary care as well. He ignored us, and we see the results all too clearly in A&E and elsewhere. The GPC has just done a workload survey. We got 3,500 responses, sort of huge response, the biggest survey that's been done, really just asking GPs what they felt things were like now compared with a year ago. And you can see the results yourself. 94% said they were working harder. 86% of you said their morale had worsened. 97% bureaucracy had increased, and all the rest of it. A real sad indictment of the situation at the moment. And this is one of the reasons why. Now, these figures only go up to 2008. Because the government have stopped recording it. They commissioned previously an organisation called Q Research to do these types of figures, but there is no current data because the government are ignoring it. It's almost as if they've got this blind spot now saying, we're not interested in your complaints and moaning and groaning. We're not even going to calculate it and measure it because it's irrelevant for us. Actually, the reality is this graph will have continued to increase, not just the number of GPs appointments, but you need to add in the number of nurse appointments. Remember, particularly since 2004, the skill mix in our practice has significantly changed. We've employed lots of nurses, and so you need to add in those nurse appointments as well to the GP appointments, and you do then see a significant rise in consultation rates. But this is the big issue. This is the demographic time bomb that we are facing now, that we're facing every day. We know that our older patients are living longer because we've helped them to live longer. They're living with more comorbidity and complex problems because we are managing those problems, but it means they come and see us more and more and more often. So you'll see sort of the bottom lines of the graph are the figures of consultation rates for males and females in 1995. The middle lines are the ones from 2001, and the top line is from 2008. So it'll be higher than that now, 5 years later. So this is why it is so hard to meet access demands. You all want to provide a quality service to your patients. That's what you went into medicine for. That's why your GPs, practice managers, nurses, you want to do the best. But the problem is the system is working against you now in so many ways. Some of the new indicators were simply unworkable. They were unavailable services. In many areas, you have got a diabetic structured education program that you can refer to. In some areas of the country, it simply doesn't exist, and yet it's a target you've been set, which is unworkable for some areas. The challenge of achieving blood pressure targets that have been reduced down based on audit criteria of 140/90 are appropriate for many patients, but not for many others. And one of the risks is that you start to chase the target rather than treat the patient. And if you chase the target, you over-medicalise, you over-prescribe, you end up sort of with little old ladies who are anxious when they see you, you check their blood pressure, you give them yet another antihypertensive, they go out, fall down, break their hip, end up in hospital, and we know what the results might be. And this is the result of chasing the target rather than treating the patient. There's the repetitive and inappropriate questioning that we have to do. It may be appropriate to ask a man about his erectile dysfunction with diabetes and explore that. Maybe doing it once, but to do it every year? And when you know that their treatment sort of is actually okay, or maybe actually you've tried all the treatments and none of it works, you remind them every year that none of it works. I mean, this is completely ludicrous, and yet it's what Jeremy Hunt wants you to do and imposed it in the contract. There's the rise in exception reporting that will ultimately deliver from this, and less time, as I've said, to treat patients holistically, to see the wider context rather than the box ticking that is generated. Now, I apologise for these next 3 slides because they are a bit busy and you can't really read them in your packs, but you might just be able to make them out on the screen. This is a survey that I did in Leeds, for Leeds LMC, asking GPs about QOF and what the impact was for them. And I asked them, what were the indicators you would most want to remove from QOF? And there's no surprise, 71%, the top sort of figure, was the GPAC survey, that exercise questionnaire that is utter waste of time, and yet you've been asked to do it. So the vast majority wanted to remove the GPAC surveys. Large numbers, 57%, 60% sort of wanted to remove the QP indicators sort of from QOF. And then the erectile dysfunction indicators that I've just mentioned, sort of the diabetes indicators, as well as the depression indicators, which leave GPs feeling depressed, let alone sort of the patient. There are some indicators which many practices and GPs felt actually, if they were amended, they would be okay. And so there's actually some clinical benefit in some of them, but actually if they need to be tweaked and changed. And so these are the commonest ones that people felt needed to be amended. So actually the depression indicator comes at the top of that list of ones that actually ought to be amended. So people were saying, yes, it is actually okay and reasonable to do a proper assessment, a clinical assessment for somebody who presents with depression. But it shouldn't be micromanaged in the way that the guidance sets out. And you shouldn't have to have an 11-point tick box to complete to actually say that you've done it. You should be trusted to do it as a clinician. If you were trusted to do it properly, then it's appropriate to say you should do that properly at the time of the diagnosis. Similarly, sort of the hypertension indicator, which I'd already mentioned, the 140/90 target, is inappropriate. If it was 150/90, if you were doing it every year rather than in the 9 months, which makes you do it in the last 6 months of the year, then it might be more appropriate to be checking somebody's blood pressure in that way. Similarly, sort of the issues around suitably competent professional being the only one who can provide dietetic advice and the micromanagement that goes with that. The expectation that you have to do things every year, things like the checking of someone's cholesterol, sort of with peripheral artery disease or coronary artery disease. It's nonsense to actually repeat these tests every single year when the results don't change and your management doesn't change. The only reason you're doing the tests is because QOF expects you to do the tests. So if you did them every 3 years or every 5 years, it may make more sense. And then there's a list of those which had least support. So taking together those sort of where there was a desire to amend or a desire to retain, which ones had the least support at all in QOF. And again, it will come as no surprise that the GPAC survey comes top of the list, quickly followed by the QP indicators, the erectile dysfunction sort of indicators for diabetes, and the dietetic review for suitably competent professionals, all the ones imposed in the last contract change. So the ones that have been there for many years, the clinically appropriate ones, have actually got a reasonable amount of support. So when we lambast QOF, actually, there is a section of QOF when you actually start to ask clinicians about it, they actually think it's quite sensible if it was moderated in a particular way. But all of the ones that have been imposed, which we have been resisting as GPC for many years, but which were just taken off the shelf and dumped on us, we resist it for good reason, because they're not the ones that GPs and practice nurses find helpful. You've also got brand new DESs this year, which I'm sure you're making haste with. You've got the online patient access one, which is in some ways sensible. It's about trying to encourage your prescribing sort of requests by the internet, sort of email requests. It's about electronic booking, but there are the risks, the risks of e-consultations and open access to records which haven't yet materialised, but could be the follow-on sort of in future years, which many people are really anxious about, and we need to get that right. The case finding for dementia, again, treating people with dementia is, and finding and diagnosing people with dementia is something you will do day in, day out, but the way it was delivered through the DES wasn't really the right way, and there's really no evidence that screening for dementia sort of is something that is worthwhile doing and potentially can cause harm. The risk profiling sort of DES, again, sort of many CCGs have done this in very different ways. In some areas it's working in a sensible way, in other areas it's become very bureaucratic sort of and overwhelming. And then there's this bizarre remote care monitoring DES. I don't know how your CCG is coping with this at the moment. The plan originally was that you were going to do remote care monitoring for hypothyroidism. Now, how can you do it any better than actually taking the blood test, getting the patient to ring up for the result and telling them it's okay? But you were supposed to sort of do it in another fancy way, sort of to actually say, well, maybe they could Skype in and get their sort of, results, sort of, or they could sort of, have some internet sort of, check that sort of bounces the results sort of, directly to their email account. I mean, this is complete nonsense. Sort of, the hypothyroidism sort of is probably the best managed sort of element of your contract at the moment, and yet some guy with a sort of a whizzy box wanted to actually make it remote care monitoring, and so you got a DES as a result. The GP survey, what did GPs think about the DESs? Well, no surprises again. 64% thought the dementia DES was of little or no benefit. That's a real sad indictment of the fact that actually dementia is the big thing that we should be sort of getting really passionate about and dealing with properly, and yet the DES didn't really address that problem. 60% thought the remote care monitoring DES was probably a waste of time, and 57% thought the risk profiling DES was a little or no benefit. Interestingly, 50%, about half, thought that the online DES was very or quite beneficial to patients. So I think that element of common sense in terms of trying to allow a few patients to be able to book their appointments online is something that many practices are actually embracing already. There's uncertainty too about locally enhanced services. Sort of many people are really worried about the future of these. This year it's been a bit of a transition year, but this might get worse in the future. And this is all about the fact that local authority has now got hold of the health budget sort of in many areas. There's concerns about the standard contract and the bureaucracy in terms of being able to apply that. The impact that's eventually going to happen sort of with local authority budgets that have been far greater hit than the NHS budget, and how that will have an impact on the potential of you being able to continue to do your local enhanced services, and then the impact of any qualified provider and tendering, and what's going to happen sort of, when a local authority, as they're starting to do a whole system-wide commissioning process for, say, sexual health services or contraceptive services, and just look for one single provider rather than every provider, and providing a proper service based on the practice. So there's lots of anxiety there related to that. I mentioned briefly the immunisations. There's a whole plethora of immunisations that I'm sure will be driving many practice nurses around the bend in terms of just trying to keep on top of the huge changes. I'm sure you've all just got going with your flu campaign and now squirting flu up children's noses sort of on a daily basis. And I think these are, again, generally to be welcomed, a focus on immunisations. The resources are new resources, so this is a little bit of new money. It isn't necessarily what everybody would want, and sort of doesn't necessarily cover all of the costs, but it is a genuine increase in investment, and I think the right direction of travel. But what does this actually mean taken in total? So for the average practice for this year, just looking at the threshold changes, the QOF loss, the organisational points loss, could be losing about £31,000. But that's without the bigger PMS and QOF and correction factor changes. So this is actually a graph that inflates previous year's figures based on inflation. So this is taking into account inflation, sort of, and how your pay has held up during that time. And you can see that the top line is your gross earnings, the middle line is your expenses, which is the key killer. That's the thing that's been rising sort of, steadily year after year and has been unfunded year after year. And that's why your pay is going down. But actually, you're still ahead of the curve compared with what you would have been sort of in 1990. So if you were a group of GPs sat here in 1990, you would have reason to complain about your poor pay. And whilst we do complain about the fact that our pay has been cut year after year since 2006, actually we're still just that bit ahead of the game compared with what it was all those years ago. But you can understand why people are unhappy when you see how our pay is falling. But this is the real issue that you really need to factor into your practice accounts and planning going ahead, because it will have a big impact one way or another. For some practices, this will be really good news. For years, they have been underfunded. They haven't had a correction factor. They've had a very low pounds per patient, and it's had a real impact in their ability to provide services for their patients. They will get inflation, they will get rises year on year over the next 7 years, potentially, as the correction factor is recycled in the pot. But it will have a big impact on those practices who've got a large correction factor, and an even bigger impact on the higher funded PMS practices as we start to move towards equality of funding. We don't yet know how much of that PMS money will flow into the PMS cum GMS pot and to then be recycled across all practices. That's something we're still debating with NHS England about. But it will have a big impact, and you need to be planning for the worst case scenario over the next few years as that money sort of gets recycled around the system. Not only have the government decided to upset most practices, they've also decided to upset most locums as well. And so they made a change to the responsibility for locum superannuation payments. The money went into GMS practices to compensate for that. It still hasn't gone into PMS practices. The government are committed, NHS England is committed to do so once they've done this PMS reconciliation exercise. They were constantly saying to us that some PMS practices already had this in their baseline, and we challenged them, say, well, tell us one practice where this is the case, because we didn't believe that was true. But they are committed that once they've been through this PMS exercise of identifying the various different funding elements, that they will resource PMS practices for the locum superannuation, and we'll try and hold them to that. But then there's also the issue of removal of locum appraisal payments. Sort of in some areas, I don't know how many in this area were paid for doing appraisal, but some areas were, where appraisers were paid for that, for their time out, sort of for getting involved in the appraisal system. That's gone. And as NHS England have started to level down to the lowest common denominator rather than levelling up in terms of payment arrangements across the country. And just to add to the woe, I'm sure you're all aware of the impact of commissioning and CCG. Some think this is great, some think this is yet another burden. The massive concern and anxiety around CQC registration shouldn't be a problem for most practices in terms of actually getting through the hoops, although it's a real bureaucratic process. The costs of the privilege of paying for it, though, is something that I'm sure sort of you are all delighted to sort of to shell out even more money to CQC as they are just doing consultations at the moment about the fee rises for next year, let alone sort of what's happening this year. So that's just going to get sort of more and more of an impact on practice expenses. Revalidation, again, sort of is something that most people are starting to get more comfortable with and are feeling sort of okay about, but again, it's just one more thing to do. The big pension changes that's had a massive impact on every working GP over the last year and will continue to do so over the next few years. Nigel's already said how wonderful NHS 111 is in your area, so I won't sort of dwell on that. And then the concern that many of us have about the commercialisation and the increased fragmentation of the NHS. Just getting things done now is so much more difficult because you've got NHS England, you've got Public Health England, you've got your commissioning support unit, you've got the local authority, you've got the CCG, and the LMC trying to hold the ring sort of, around all of those. Really, really difficult. And then it's no wonder that young doctors don't want to be GPs. And older doctors are just looking for the exit door as quickly as they can. There is a recruitment and retention crisis in general practice that's going to have a massive impact on every practice. And the government focuses on attracting new doctors to A&E, where it's also hard, but actually A&E, psychiatry and general practice, those are the areas that doctors do not want to apply to at the same rate as elsewhere. So I think we've got a real problem on our hands. The government commissions a GP work-life survey. The University of Manchester and various others are involved in producing this. Surprisingly, they didn't want to publish these results sort of this year, and they sort of kept them a bit quiet. Instead, they fed the Daily Mail or the Daily Telegraph, one or the other, with some spurious story about GPs wanting more pay. What the story really was that actually GP morale is at rock bottom. The lowest level of job satisfaction amongst GPs since the introduction of the new contract in 2004, the highest levels of stress since they started this survey, and a substantial increase in the last 2 years in the proportion of GPs intending to quit within the next 5 years. This is real issues. This is not something that BMA has done. This is not something that we've dreamt up. This is the reality of general practice today. And these are some of the things that are behind it. So consultant numbers, the red line, have been shooting up. The workload that has been done, and everybody in the NHS is working harder, but in hospitals they seem to have a knack of being able to employ more people to do that work. Whilst the numbers for GPs in terms of full-time equivalents has increased a little bit, it's not increased at the same rate. And so now you're seeing sort of that the proportion of doctors who are GPs is falling. Sort of the upper line is the doctor headcount, the lower line is the full-time equivalent. It's probably worse than that because we know we're not very good at actually working out what a full-time equivalent figure actually is. So it's probably worse than that. This is why it's very difficult to maintain the workload and quality sort of within your practice. And a body called the Centre for Workforce Intelligence produced a major report last year, and this is one of their conclusions about general practice. Our analysis on the available evidence on the demand for GP services point to a workforce under considerable strain and with insufficient capacity to meet patient needs. There is a need for more GPs. That really is the bottom line. And at the moment, the government aren't doing anything seriously to address that. And this is the reality. These are figures sort of related to the share of NHS funding that general practice receives. And you can see, whilst there was a slight increase in the funding that we got in 2006 related to the new contract changes, it's been a steady decline since then. And actually the reality is worse than this. The figures that we have just been crunching sort of over the last few days since the recent issue of the investment report by the Information Centre last week suggest that when you take out prescribing costs, because dispensing prescribing costs are wrapped up in these figures as well, take those figures out and you're less than 8%. You're looking about 7.7% of NHS funding which goes to support general practice, where 300 million consultations occur every year. I mean, this is just scandalous, and this is why you're having such a difficult time. As a result of the concerns that we all are aware of, there's been a plethora of reports suggesting how things can change and develop. And if you've got some shortage of books recommended for your Christmas list, maybe sort of choose a few off this list just to sort of to read under the Christmas tree instead. A whole variety of different reports, all very much saying similar things. But then Jeremy Hunt pops up not only has he imposed all of these contract changes, which have caused all the problems, then he has this Damascus Road vision that actually says, oh, I shouldn't be causing more and more work and more box ticking, I should be reducing it. And so now his plan is to try and do that. But he wants you to effectively return to a Dr. Finlay type of nirvana, sort of, which never really existed, but using modern technology at the same time. So he wants you to be accountable for vulnerable adults or those over 75. We're not really quite sure what that accountability actually means. Is it really blaming the GP for when things go wrong in the hospital or in the community on a Sunday afternoon sort of, or last thing at night? Greater involvement in out of hours, because that nasty 2004 contract is the real reason why everybody's going to A&E, which is complete nonsense. The King's Fund has actually showed that very, very clearly, that the number of people going to A&E hasn't really risen that much at all. It's actually people going to walk-in centres and all the rest, because we've actually increased the accessibility. We've opened up another lane on the motorway, and so it's the supplier-induced demand that we've created which is causing many of the problems. And that's not our fault. That's the way the government have prioritised access and open access that's disempowered patients rather than empowering them. He wants to have open access to patient records, which I've already focused on, and he wants you to do the friends and family test, which is basically asking, sort of, you know, would you recommend this service to your friends and family? And he wants every practice to do that. And then we've got this nice, friendly chief inspector of general practice who will come knocking on your door and say, let me have a look at anything and everything, and potentially could be a big stick that CQC start to wield in the future. So, briefly, how could practices respond? Well, I think you need to remember and have at your heart the essentials of general practice. What really makes general practice the success story that it is worldwide? And that's about the registered list. It's about having a community that you genuinely look after. It's about being specialists who are generalists. The fact that you treat patients holistically, that you know a bit about everything and are able to treat the patient in front of you, rather than sort of, you know, becoming much more narrowed in your view. It's about the continuity of care that you offer to patients. The fact that you're there in a practice probably for 20 or 30 years potentially, and are there for them, not just you as a GP, but you as a team offering that continuity of care, coordinating patients' care, being prepared to stand up and say when things are going wrong, because you are not forced to toe the party line by some management elsewhere. You are independent advocates. That's why the independent contractor status, which has been the subject of lively debate in the medical press over the last couple of weeks or so, is actually so important, because you have the freedom to be advocates for your patients. You're not squashed by some management hierarchy elsewhere. But you are locally accountable, and I think that's something maybe we need to focus on more, is how we can be more accountable, more open, transparent to the population that we serve, and how we involve our patients and local population far more in our practice. But you are flexible. You are willing to change. For goodness sake, we have to. There's been so many changes over year after year after year. If we didn't, we'd be annihilated. And so we've got used to being rapidly changing. And we still are able to manage risk. If we couldn't, the NHS would go bankrupt. if we didn't manage to manage people and be brave enough to manage people in the community, rather than referring every second patient or investigating every second patient, the NHS would not survive. So, protecting patients is really crucial and really important. So don't chase every target that pushes patients at risk. It's not potentially financially sensible for you to do so, but it's not in the patient's interest for you to do so. Limit your workload and manage quality. That's a difficult balance. More and more GPs are starting to get it, that actually sometimes it's better to maybe do a bit less and potentially get paid a bit less, but actually to do it better and to feel better about doing it. We need to be really careful, though, as we try to manage our budget with our practice, that we don't do what the worst of practices do, which is skill mix to such a level that you actually lose that GP involvement. We need to value GPs, and we need to ensure that GPs retain a full and integrated sort of role within practices and not skill mix down to offering really a nurse-led service or even a healthcare assistant-led service. We need to prioritise our practice. That means doing sort of, those important QOF areas sort of in the next 9 months. It means considering whether we can actually afford to be involved in some of the external stuff that we might like doing, but actually is maybe not necessarily cost effective for our practice to do. Sort of how we're really ensuring that the resources backfill the time that we're away from our practice properly. And we need to be much firmer and clearer, and the LMC, I'm sure, will help with this, in terms of actually saying, well, actually, we'd like to do this, but if you haven't got the resources, we can't do it. Not because we don't want to do it, it's because we simply think that actually doing more and more is going to impact on the quality of service that we're offering to our patients. We need to think about developing our practice. In the next session that we have with Nigel, I think he's going to talk a lot more about this. What is it that we can do to respond to the new world? We might not like it, but how do we respond to survive? And that might be about developing new services in our community, in our practice, through AQP where possible. It might be about working together in bigger groups, whether they be federations or co-ops or call them what you will. But we need to think bigger and how we can cooperate with those people who in the neighbouring practice who we've ignored for the last 20 years. But maybe actually we need to start working with them a bit closer. Because by working together, we might be able to share staff, we might be able to share community staff, so that we have a genuine community service that's built around the practice, that we take control of that and not allow others to do it. Because undoubtedly, the integration agenda is very much on people's minds, and if we're not careful, we will have things done to us rather than us actually leading that and making it happen sort of in a way that is beneficial to our practice and our practice population. We need to protect ourselves, and I know there's a session sort of later on about health and well-being, but we need to get that good work-life balance. We need to be very careful that we support partnership development and don't expect more and more GPs to become salaried GPs, whilst recognising that some salaried GPs want to be salaried GPs for very good reasons. And we need to support sort of our colleagues as they move towards retirement. CCGs have a crucial role to play. We need to really hold them to account and say, look, PCTs failed to do this, health authorities failed to do this, you need to shift resource out of secondary care. There isn't a pot of new money sitting somewhere else. We need to actually use the resource that is funding NHS and social care, but more of that resource needs to come into general practice. And CCGs have the ability to do that if they are strong enough to do it. They will need to commission integrated care. They will need to support practices working together, and particularly to limit the bureaucracy. What they can't do is work in old ways of just saying, well, we're going to set you more and more targets to make you run around the hamster wheel faster and faster so that we can feed our masters up the NHS England food chain to show that we're doing the things that they want us to do. We can't work like that. We have to be trusted to do things properly. So, yes, there's increased workload, there's decreased income, so we've got concerns about the quality of care that we're offering to our patients, and all of that is leading to more stress and burnout. That is undoubtedly the case that that's what's happening. So we need to take more time to be more business-like, to work our practices sort of, so that they're financially viable and stable. We need to protect our patients and GPs as we go about doing that. We do need to grasp this nettle of developing our practices. There is a real opportunity to do that. And we need to actually have that time to start to take control. Because if you're in control, then the stress and the morale will start to disappear. Thank you very much.